fellow dinks. Welcome to Wednesday. It's hump day as always, and that means it's happy hour for the dinks. So welcome to Dentists in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It's live, and tonight over a nice little bottle of Leviathan, nice little blend, and pretty excited about that. So you know the routine. Along with me are Dr. Chad Duplantis and Dr. Jennifer Bell. We're all practicing dentists. We are all educators, and we are all business owners. And our job is to bring all of you in the know. We've got an amazing show. I'm going to bring Chad and JB up right now. Here they come. Hey, we got to get to some news because, you know, we have a hero for me as our guest tonight. So I'm so thankful he agreed to do the show. Yeah, tonight we've got Dr. Brian Shah, the incredible oral surgeon, physician that took over the Piper Clinic, handling all of the surgeries down there in St. Petersburg. He was very involved in education prior to that. He comes from Chicago, but actually moved down to St. Petersburg to take the helm since Dr. Piper stepped down from doing surgery. So anyway, I'm really excited to have him here. His name is Dr. Brian Shah. Stick around for a few minutes. We'll be hearing from him, talking everything about the TMJ world and sleep and surgery and all kinds of great stuff. But first, JB, do you have some news?
All right, guys, let's talk about a couple of things. First, a little bit of a self-indulgence because the state of North Carolina made the ADA news today when they awarded a duo honorary membership, one of which went to our very own Prissy Allen. So Prissy has been the probably the leader really running the North Carolina Dental Society for quite a few years now. She's been there since 2006, but a part of the North Carolina dental world since she was a dental assisting student back in 1967. When you think of the North Carolina Dental Society, you probably think about a lot of things, the Myrtle Beach meeting, etc. But you absolutely think of Prissy, and she's been such a champion of dentists in North Carolina for such a long time. So a bit of a self-indulgence here just to make sure she gets credit where credit is due. We're really excited and honored to see that she was nominated and recognized for her long commitment to dentists in our state. A bit of other interesting news. Each week, month, we've been reporting on some of these HPI data points that have been coming out as the ADA has been collecting different statistics over the last few years. And this one kind of hit home a little bit, and I think many of us have been feeling this, maybe couldn't even articulate, and frankly have blamed COVID for a lot of these issues. But the interesting thing that is coming out of these statistics is showing that there's a decreased enrollment for allied students. So both in dental hygiene and dental assisting. Dental assisting actually started pre-pandemic where they started to see a decrease in enrollment. Dental hygiene has seen that post-pandemic. But combined, they're both seeing a pretty, at least statistically noticeable decrease. And so, for instance, there were 8,197 first-year dental hygiene program enrollees in 21, compared to 8,300 enrollees in the 2019-2020. So that's a decrease of 125 students. And certainly many of us are feeling that because we had a pretty significant number of dental hygienists that also left the market simultaneously because of COVID. So I do think that it is an interesting phenomenon that we are finding ourselves in where there's an increased number of dental schools opening up, but no increase in dental hygiene and dental assisting enrollment. This is not a sustainable path. Dental dentists need their allied support teams to be able to do their job. And yes, I know we have members of our group that do their own hygiene and et cetera. But the majority of us need some level of support from either multiple dental assistants or a combination of dental assistant and dental hygiene to be able to run a successful, rewarding practice, and to be a part of a cohesive health team. And so I do find this statistic concerning. We're seeing it in North Carolina when we look at the number of licensed dental hygienists compared to the number of licensed dentists. And so, we need to bring awareness to this and certainly need to see if there's some opportunities to continue to raise awareness to get folks enrolled. The last bit of news that I'd like to highlight was a study that just came out from the Journal of American Dental Association, kind of highlighting some of the common factors that are influencing prescribers to prescribe opioids. Overall, since 2018, when a lot of the new requirements came out by a state and for additional educations, and most of the states have mandatory database systems that they're operating in for their opioid prescriptions that we have to check as well, that we have seen a pretty substantial decrease in the number of prescriptions that are being written for opioids. But 1 out of 4 dentists are still prescribing them 1 out of 4 patients, who are undergoing surgery are still getting opioid prescriptions. Fine. I mean, they certainly have their place in dentistry and certainly help us manage acute pain issues related to post-surgical. We can ask our guest tonight what his post-operative management is of pain for his invasive surgeries, because certainly what he's doing is far more invasive than a simple tooth extraction. But we're seeing the decrease of opioid prescriptions. But it does seem like still the more advanced the surgery is, the more invasive, and the longer the surgery is, we're still seeing pretty consistent opioid prescriptions for that. Overall, I still see this as a win because the data is still showing that dentists are sort of taking ownership of whatever participation they need to in the management of the opioid prescription crisis, and they've made significant changes to sort of embrace that. So with that, guys, that's the news.
JB, it really bothers me what you had to say about the auxiliary staff shortage, because I have a former team member that was trying to get into hygiene school, and they're really still limiting the class size so much based upon the volume of applicants. You've got people that are willing and able and wanting to provide. I know that there's some that can be weeded out just due to grades and stuff like that, but you've got really qualified people that want to share this passion, and they're needed. And they're not increasing the number of schools. They're not increasing the class acceptance size. I'm not really sure what it is, but I don't get it. We need them now more than ever.
I'm surprised that on the assisting side, because it seemed that so many practices were opening up assisting programs, maybe not hygiene.
Well, if I can interject, Jeff, those were only DA1 licensed programs. The majority of them are not opening a DA2 because a DA2, the requirements to have a DA2 program, that's well over a year because of the chair, because you're basically getting your 3,000 hours in a consolidated format.
Right. Well, and that's the point, though. But these DA1 programs were fast, they were inexpensive, and they gave people immediate experience. And so getting to that hour benchmark was really pretty easy for them to go ahead and become certified dental assistants.
I number one, I'd have to check the data, and I will get back. I don't know if DA1s are classified in the dental assisting. I don't know if they were just looking at DA2 programs with certified dental assistants.
Yeah, I'm curious about that, because there were a lot of dentists were opening these adjunct programs, but hygiene I get. It's
I don't know about you guys, but I'm not seeing any new programs in hygiene opening.
No, not at all. Just more dental schools.
Right. Well, in North Carolina alone, in the last 10 years, we're on our third. So in 10 years, we've opened 2 schools. We'll open our second in theory in August, and not one new hygiene program has opened to combat both what both you, Jeff, and Chad are experiencing of an influx of a new population of folks moving in who are dentists who are looking to practice in the area, and an influx of graduates wanting to stay. So, you know, there's a lot of activity. There's a lot of doctors wanting to stay and work. We need support people.
Yeah, for sure. Well, what do you guys say we bring our guest on?
Love it.
Let's do it. So, as you guys know, a month ago or so, I was at the annual, one of the Piper symposiums, and I had the pleasure of finally meeting Dr. Shah, who we were writing back and forth. We're, you know, part of the same study group. So I had just not met him in person. And all the while, because during COVID was when he came in and took this whole thing over. And all the while I thought, boy, those are just some pretty big shoes to fill. And the expectations that are going to be there, I mean, that's just not something that anyone could step into. And literally, after listening to Brian for 5 minutes when he spoke, I said, oh my gosh, this is the guy that is going to bring this into even the next level of education and the next level of incredible care. It is just such a robust program down there. I am so proud to be a part of it. I'm so thankful that Brian came on. Let me just tell you a little bit about him. Dr. Brian Shah, he was born in Chicago, Illinois, grew up outside of Cleveland. Sorry about that. He did it.
Go Indians!
Yes, exactly.
He did his undergraduate studies at the Miami University of Ohio, I might say. Went to the Ohio State University College of Dentistry. By the way, I hated going to OSU Pittsburgh games because we always got our ass kicked. So let me just throw that in there when that happened. But anyway, he was actually very well known in the oral surgery department. He was lucky enough to work with Dr. Larry Peterson. He received a research scholarship from the Department of Oral and Maxillofacial Surgery. Obviously, that needed to be his path. He then went on to Harvard Medical School, where he received his MD and his oral surgery degree. Did rotations at Mass General, Boston Children's Hospital, Brigham and Women's Hospital, excuse me, and of course Conway Hospital in Conway, South Carolina. No, the last one isn't true. Anyway, he was
illustrious.
He was lucky to find 2 teeth in that town.
Yeah, you're gonna need a MapQuest to get that one honed.
Exactly.
He found a joint there. It just didn't happen to be a temporal mandibular one.
That's right, Chad. He got his board certification from the American Board of Oral and Maxillofacial Surgery. He was in academic practice at Yale, and he was in private practice in Chicago doing amazing things. And then he and Mark got together and made this incredible thing happen. And I am so thankful because just the comfort level that I feel and having heard you and knowing your knowledge base and how objective you are in your therapies and your surgery choices and your choices sometimes not to do surgery. I'm just very impressed by that. So Brian, welcome to Dinks. It's so great to have you.
Much. It's really, really a pleasure to be here. And what a beautiful intro. I should have had my wife in the room. Yeah. Actually, when we were doing that, because I think that might have helped me a little bit.
Yeah.
But no, Jeff, honestly,
it never helps.
No, I actually felt the same way. I think you and I hit it off very quickly. That we have this uber energy for these patients that many folks run for the hills when they meet them, and we go right after them. And we chatted quite a bit in South Carolina and had a lot of fun together. But thank you for having me here, and I really appreciate it. Anything we talk about tonight is going to be a lot of fun for me as well.
Well, I love it because anytime I can get my nerd on with a fellow nerd, it makes me happy.
Exactly.
So why don't you, if you would, tell us a little bit about that journey from private practice, how the conversation started with Dr. Piper, and how you two ended up collaborating, and how you ended up actually taking over what was the Piper Clinic in St. Petersburg, Florida.
Yeah, it was, boy, if you don't believe in fate, this story will kind of to get you to believe in it, because it just wouldn't have happened otherwise. I was in Chicago, building my private practice pretty much around orthognathic surgery. Now, of course, I was doing the full scope of surgery just to pay the bills. And one of my referrals that many of you may know, Jim McKee, said to me, and there is a guy in Florida that I think is the missing link for the work that you're doing here in Chicago. And I'm like, dude, what are you talking about? He's like, this guy's a TMJ wizard. He understands structurally how the joint relates to the face and vice versa. And I don't think you can do orthognathic surgery without understanding what he's doing. And when he was mentioning this to me at dinner, I was seeing a ton of relapse patients, not necessarily people I've operated on, but I actually had a little joke in the office that all of these patients were the same person. They were about 30 years old, female, had anterior open bites, treated successfully in the past with orthognathic surgery and orthodontics, and now they're in my office with open bites, and we get scanned. We're like, oh my gosh, you have 6 plates in your face. What happened here? Well, my teeth used to fit perfectly, and then something happened. And I was, digging through the literature and our research that talks about relapse in orthognathic surgery often focuses on the hardware we use, whether we have enough fixation, whether we've expanded the soft tissue envelope too much, et cetera. And it started to click that in these particular patients, at least, the relapse was happening not at the plates that we put in or at the soft tissue envelope at the front of the face. It was they were losing dimension at the foundation. And what I mean by the foundation is the temporomandibular joints. So you have a patient that has a skeletal problem that likely occurred because of TMJ pathology. You fix that, quote, secondary deformity, but you never fix the primary pathology. And that's where Mark and I clicked. And that's what got me to come down to Florida. And it's really, really been lucky. I mean, it's been fantastic. So not only do I thank Mark with all my heart, but Jim, because he made that introduction.
Oh, Jeff. Mute.
Sorry, Jeff was echoing, so I had to mute him just because he also gets excited.
I do get excited.
He talks over people. Sorry, Dr. Shah. I apologize.
No.
How much of that, though, happens both in dentistry and in medicine, where we just treat the symptoms and fail to identify and recognize the etiology?
Yeah, I absolutely hear you, and I'll tell you, I think we're still failing to a certain extent, as much as we know about the joint, and I live in that part of the body every day and see it every day. I still cannot, with an honest face, tell a patient I know what caused the initial problem. Now, we have theories on trauma, of course. I mean, if you bump the chin hard enough, you're going to knock the disc off the bone, and then you have internal derangement, et cetera. But why does it happen in predominantly female patients? Why doesn't it happen in the male football player or boxer? They're hit in the face many more times than a young girl might be if she falls off her bike. So we know from some of the great work that the guys out west have done, and that there is a female predilection. But can I really say to someone, well, it's because you had an estrogen surge at 10 years old and your mom has a small chin and now you're predisposed to this pathology? I don't know if I can say that. So I think we're still failing on that level, but as long as we're excited about it and we keep looking into it and do it with sort of proper science, I think we'll eventually get better than where we are today.
So
And go ahead, Chad.
okay, Jeff, I got to go here because this
Please.
is just a fantastic conversation. This morning, new patient comes into the office, had been to another dentist in the area, was not thrilled, came to me because we have several of her friends that we see, and she comes in and she's telling me kind of her story. She's wearing a night guard. She's got pain mainly on the left side. And so the first thing that I looked at was her occlusion, and I'm taking a look. And I'm looking at her occlusion. She's missing both of her second bicuspids congenitally. She's got a space there. There's nothing in where those teeth should have been. She's got about 7 millimeters of overjet, about 1 to 2 millimeters of overbite, and she's only hitting on her first and second molars, and that's it. And she's having excruciating pain on her left side. Her joints feel okay. They sound okay. There's no popping. There's no clicking. And it was my first visit. We're just kind of talking things through. So let's say you see somebody like that for the general dentist like me, who's not Piper trained. Where do I go with this patient? I mean, and I have an orthodontist that I really like that I want her to go to first. And then I've got a surgeon that I want her to go to second. But that's the route that I would take. And so what would you recommend to somebody just like me that's just kind of starting to really get involved in this and delve in it?
Yeah, great. Absolutely. And I think that is the place to start, and it's structure.
Mhm.
It really is structure, as simple as that. We have a patient that even without the complaints of pain, they now have a malocclusion. And let's just start with the simple malocclusion, is that if that's new, how did it become that way? If the back teeth have lost all their anatomy, if you're losing height, why? What is going on that's causing that? And the first simple modality can be a CT scan. And,
Yes.
and it's so ubiquitous now that we can do three-dimensional reconstructions and look at these things. And then I start with the basics, the 3 S's: size, shape, and space. So how big are the condyles? Do they fall within the normal range that Mark has described for us, 120 to 140 cross-sectional diameter? What about the shape? Did they look irregular? Are they odd? Are you seeing obvious arthritic changes? And then articular spacing. I mean, if there is a disc living where it's supposed to, you've got to have 3 or so millimeters between the skull base and the condylar apex. And it's rare if you don't. And then there's subtleties to all of those things. But, I think MRIs are the gold standard by far. And in a perfect world, we could all do it. But I think the screening tool, which we all have access to, is the scan. And you start to pick up on those subtleties. And I really, in the past, I thought it was overcalling it. I was trained the typical way most maxillofacial surgeons were. And unless I see a tumor and blood coming out of the ear and a hole in the brain, I'm saying, you're fine, rub some dirt on it. But you pick up on these subtleties and you start to say, wait a second, this is not the way you were born. You weren't built this way. And there are studies that show in children. So actually what they did is they did MRIs of kids that had brain pathology. And they found that their discs were all in place. All of the discs were in place. And so it's not normal to have a disc that's herniated. Now, can you adapt to that? Sure, absolutely. But is it, quote, normal and healthy? No. So, you start to pick up on those things, and that's the first step, I think, is with the simple imaging. Then you can measure ramus condyle unit height. So on the particular patient that you have, Chad, if the left side is significantly shorter than the right, why is that? That shouldn't happen. And if you have old records on them, was it always the case? So now you can start to be a detective and say, did this happen since development? Or was there a traumatic event that the patient is now losing ramus condyle height on the left, causing asymmetry, pain, all of the things that you're seeing. And you kind of get it like that.
Brian,
That's interesting.
I love what you just said. I'm going to throw something in here, Chad, because I think this is one of the most important things that he said. And he just gave us so much incredible information that it may have gotten lost in there. But it's looking at that occlusion and saying, not here's what I've got, but how did it get this way?
Mm-hmm.
Yeah.
Because occlusions, I mean, we are meant to have bilateral, simultaneous contact of equal intensity posteriorly. And when that is thrown off in the absence of any other work, we need to figure out where it's breaking down. And that immediately necessitates a CT scan to say, is the foundation intact? Because it's all connected. And if the foundation isn't intact, perhaps that's the reason for the asymmetries and for the bite changes. In dentistry, would you agree with this, Brian, that we've looked at occlusion as the culprit of TMJ problems as opposed to the manifestation of TMJ derangements? You know, we've kind of looked. Yeah.
Absolutely. I was always taught, and here's the thing, sort of raising the blinds and actually seeing things for how they are. You know, we're always taught your TMJ patients are typically class 2 because they're trying to posture into a class 1 relationship. So they develop, quote, TMJ, TMD, whatever that really means. Why are they class 2? The joints were bad to begin with. That's why they have pain, because they have pathologic joints. It happened before the completion of growth, and they have a class 2 mandible. Now, could it be the other way around? Certainly, for sure. Someone could have a genetic small mandible. They can continue to posture. Now, the front of the condyle is hitting on the back of the eminence. That's not good. That hurts. And the lateral pterygoid's being overworked. That hurts also. So there has to be room in how we approach this very complex disease for open-mindedness, that it's not necessarily the chicken or the egg. It can be both. And as soon as we get more elegant in our thought process, we'll say that I don't really care which one it was. I want to fix it or prevent it.
Can you give our doctors a better understanding of what current surgical treatment modalities are available to patients? You know, frankly, coming from my post-dental education, really didn't think that surgical options were really good and that there was any good prognosis associated. Of course, I think a lot of those were around artificial condyle surgeries. And so, you know, feel free to provide your feedback on that as well.
Yeah, thank you. That's a great question, because I think, again, I was just like that also before I joined Mark. We had these sort of standard industry type approaches to operating on the joints. And, you know, as residents, we ran the other way when we saw patients come in to the one joint surgeon you may have in your department, because they're typically, none of them can move their eyebrows. They've had 15 operations and they're still in pain. And then they're walking down the hall to the orofacial pain clinic to get their narcotics. So in my mind in those days, and it was, wow, I thank goodness we're trying, but we're not fixing these people. So, you know, the options that are out there, it runs the gamut. So on the very minimally invasive side, we have the good old arthrocentesis, which the concept is that you're entering the superior joint space. So the superior synovial joint space, and you're flushing the inflammatory mediators. And this is based on some work that was done by Dr. Nitzen talking about internal derangement being caused by reperfusion injury and generating oxygen-free radicals within the synovial fluid that then cause a loss of lubrication, inflammation, stickiness, disc dislocation, and arthritis. I think that can occur. I have yet to see a patient with severe condylar arthritis and good discs.
Mm-hmm.
So maybe I'm just catching them further along. But the point with the arthrocentesis is you wash it out. So my contention with that always is, okay, you've washed it out. Now they feel good for 9 months is what the literature says, but you didn't fix the original pathology. So is the original pathology that they're parafunctional, or is it something else? And so that's the arthrocentesis. Some people will put hyaluronic acid into the superior joint space as a lubricant. Some people will put in steroids. Personally, I would recommend against the steroids because I see what the joint looks like after it's been done, and it causes a lot of scarring, not good. Does make them feel good though initially. Then you have the arthroscopy, which is looking in the joint with a little camera and then using another port to operate. And this can be done successfully, and we could talk about that for a long time. But what do we mean when I talk to patients about this? What do we mean operate? What are you doing with that other hand? What are you trying to accomplish?
Mm-hmm.
Are you trying to fix the disc, move the disc, take away adhesions, etc., repair a disc? Most of those things are quite difficult to do, except for breaking adhesions, which are scar bands, basically. The other utility there is it has, quote, diagnostic utility, because you can see in the joint. You can look for hyperemia. You can look for these adhesions. But I would argue that MRI is going to do that without making a puncture into the face. Then you have the middle of the road procedures, which is where I live most of the time. And these are things where we go into the joint. It's an arthrotomy and then an arthroplasty, where you open the joint and change the internal structure. And the workhorse in my office is removing the disc and then reconstructing the joint with a fat graft. And the other side of the spectrum then is, if you don't believe you have enough healthy tissue left, then you've got to replace it, either with a rib or with a total joint replacement. And I do those. There are utilities. I think that this practice unfairly has had the reputation of not doing those procedures, but I have multiple cases scheduled and we've completed multiple cases. But it has to be a clear indication to take someone and remove what they have and replace it with either an alloplast or a rib graft, because that's not benign. And my last little kick on that is I will only do custom total joint replacements. I'm not doing stock replacements, which is essentially small, medium, large, pulling it off the shelf and doing the procedure. So it's custom made to the patient.
Interesting. Well, I didn't even know there was custom.
Yeah, how do you custom make them?
Yeah, so it's really pretty cool. So TMJ Concepts was acquired by Stryker, which is a plate and screw company we've been using for years. And with the computer modeling that we have right now, the components can be designed on the computer and fabricated. Now, in the past, this was waxed up just the way you would a crown. You had your ramus component, your fossa component, your condylar component, and you would get a stereolithic model and kind of change the bones, do your Lafort, move the mandible to where you want the maxilla to be, and then you'd fill in the gap with the wax and the wax up. Now it's all done on the computer. So it's specific for the patient. Sometimes you have to stage it. Sometimes you can get your cutting guides and do it all in one appointment. So I think that's also a game changer.
And what are you, pardon my ignorance, but what are you cutting to fabricate?
Yeah, no, great question. So you have to remove the native condyle. And what you're doing is you're creating space for the fossa, which is going to be a high density plastic plus your titanium basically screwed into the zygomatic arch. And you want to create that space from the ascending ramus up into the fossa. So you're taking away the native condyle to allow for the proper geometry to get those components to fit. When I use these, It's typically when there's not much condyle left anyway. And I don't think that I can build the patient's face on their native condyle, or if there's so much disease, whether it's avascular necrosis or some sort of tumor, there's just nothing that I can do with a fat graft. Then I have to go with something that is a full reconstruction of both hard and soft tissue.
So
Wow.
Brad, let me jump in on a couple of these procedures, because one of the more common things, and especially before I became better educated on the joint and the procedures that were available, one of the most common procedures we hear from the oral surgery world is arthrocentesis, or injecting that superior joint space with a steroid. First thing, would you agree that it is not an easy thing to find the superior joint space most of the time?
Jeff, thank you. I actually, I want to do a study where we take first-year residents, sixth-year residents, 6 years out of residency, 10 years out of residency, and put that 18-gauge needle into the superior joint space where you think you've got it, and see how close you really are. And, one of the things I didn't mention, and I should have with surgery, is we do disc repairs typically in children. But when you're in the joint and you want to keep the structure, which you do with an arthrocentesis, you don't even want to look funny at anything that you're not operating on. You don't scuff cartilage. You don't just get in there and bang things around. You're creating more scar, more inflammation. So I've always contended that we think we're doing something that we may not actually be doing. And, the other side of that coin is what Mark would always argue: the real pathology is in the inferior joint space, and you're not even addressing it. So that's your junction with the condyle. So, I've done plenty of them. We used to do them with the residents at Yale. I do them in my office in Chicago. And sometimes I would see the patient the next week and I'm like, why are they so happy? How did that work? I mean, I thought I was there. I thought I was in there, and that's what the literature says. But man, they're great. But sure enough, it would have an expiration date.
Yeah, I could see that. But I also wanted to mention, and the reason I wanted to make a point of that is because I think that, especially from most general dentist perspective, is that we're just going to do some arthrocentesis, flush it out. We can't do any harm. No, not the case.
Right.
Can't do any harm. We're just going to see if we can get them better with that, or the steroid injection. And we also know that steroid use, and especially overuse of steroids, can be associated with connective tissue loss. Mm-hmm. So, it's something that I just want people to find that place where there's somewhere that they can send a patient to if they're not familiar, and not say, okay, the oral surgeon just says he's going to do arthrocentesis, or, just says they're going to do a steroid injection. And this is not to beat up on the oral surgeons out there, but as you know, there are very few that really can spend the number of hours that it takes to really learn the nuances of this complicated joint.
Well, and to that point, I think the oral surgery community, we know as a group that overall, this is not the strongest thing that we do. We can put a face together better than the plastic surgeons, certainly better than the ENTs. And, but when it comes to the TMJ, there's been a lot of trial and error. And there's been a lot of failures along the way. And we should learn from those mistakes and we really have to be hypercritical about what we're treating also. So by talking about Nitson's work with the arthrocentesis, that assumes that the internal structure of the joint is correct. So if you have a herniated disc, are you really working with a superior joint space that's even viable anymore? Right. If the disc is in the lateral pterygoid, what are you flushing?
Right.
So, if we're going to be honest with ourselves and try to continue to improve, I think these are the questions we have to ask.
Yeah. And I think that one of the things that's been undervalued is disc repair in young people, which you mentioned.
Mhm.
And this is really when we want to be catching our
Yes.
temporomandibular joint disorders, because so many kids, I heard a great radiologist. I don't know if you've ever heard him speak. He's out of Chicago. I'm trying to remember his name. Yeah.
Oh yeah.
And,
Oh yeah.
And
He's
I
awesome.
heard him speak one time, and then we had a lot of conversation on the side. And as a radiologist, he said, I've never seen another joint in the human body that looks as bad on children as what I've seen. Like, you
Right.
just don't find any other joints in the body that look that bad at a young age. And so that's, a lot of that is the trauma side of it. But we have this unique opportunity to pick these things up early, and just by getting support over the condylar head again, we can return growth to normal and make these kids more normal. And yet we're so reluctant. Oh, we're not going to do surgery on a kid. So just what are your thoughts on that real quick?
Yeah. So exactly. The thing I think that we have to also eliminate from the nomenclature with this stuff is conservative versus radical therapy. And, as my chairman, Len Cabin, used to say, it's not a political discussion. It's either the right thing to do or the wrong thing to do. And so that means the operation can actually be the most conservative, quote, thing for the child, because it may prevent 15 years of pain. It may prevent addiction to drugs. It may prevent all types of unnecessary treatment if it's taken care of when the pathology actually occurs. Now, with regards to growth, I'm really excited about these concepts. There is some awesome data coming out of Asia where they are getting some pretty nice disc repairs with arthroscopies, and sort of proving on MRI that they're getting growth of the condyles. Now, in our office, we have anecdotal data. So Mark and I have some cases that have turned out awesome, where it's like the case that we show, because it's the asymmetric kid that now grows to the midline. My experience over the last 3.5 years has been I can get them close. So I can get some growth, but if they're on the pathway already of having a significant asymmetry of the entire maxillomandibular complex, it's hard to reverse that. But that may be just because I'm not catching them early enough, or there could be a critical point where the amount of growth potential is lost. But I do think we get the growth, but we need to prove it, and we need to keep working. And I think even along the lines of decreasing chronic pain, pain is one of the worst things that we run into, because I hate those cases. I mean, I'm a dumb surgeon. I want to fix boxes and pound in nails and stuff like that. But when I do that and they're still hurting, then that makes me upset. And it's a tough problem to fix. Usually it's because now they're in the realm of chronic pain, and we've waited too long.
Well, that reminds me that we need to probably get you back and have a whole separate episode on pain.
Oh yeah,
we didn't even touch that tonight.
Yeah.
So
exactly. I know.
That's a whole can of worms.
Yeah, that is a can of
It
worms.
is.
Hey, Jeff,
Yeah.
Partha had a question. Do you want to ask it, or do you want me to?
Go ahead.
Okay. So everybody, Dr. Shah, has talked about how great discussions we've had tonight. So thank you for everything that you've done. And by the way, you're so well spoken. I could listen to you for hours.
Mhm.
Oh, again, we need my wife in here.
Yeah. Well, next time we're having a scotch and we're going to discuss pain.
Yeah.
But Partha asked a question. He said it was a dumb question. I think it's a great question, but it says, has balloon arthroplasty been considered for TMJ maladies? he had watched a procedure on this for rotator cuff surgery and was wondering if they were utilizing it in the joint space. So I'm just curious, is that a possibility or something that's being done?
Well, to my knowledge, the balloon itself is not being utilized a lot. I could be wrong on that, just because I don't do a ton of the balloon arthroplasties, because I'm in there. So I can see it. I have everything is done with a microscope, so I can just do it with microscopic instruments. But with a scope, in theory, if you were to insufflate the superior joint space, you could knock down or break up your adhesions that way, which would be an interesting concept. And I suppose it may be a bit less traumatic, but at the same time, if you're in there and you can see and you can navigate with the camera, you're going to be able to find all the nooks and crannies. And that's one of the problems with the TM joint, is that there are nooks and crannies. I mean, once you get sort of anterior and you're running into the lateral pterygoid, there's a lot of scarring. And you think it's a simple band that you're taking down, and it bleeds like stink. Now, if you have a scope, you can't see anything. So it ends up being kind of a scary cave that you're working in. And the other thing is, on the medial side of the joint, the same capsule that we're looking at laterally, we have medially, but you can't get to it. Just beyond that, you have major arteries. And if you get into any of those things, you have to go to interventional radiology, because you just can't get to those vessels to tamponade the bleed. So you want to visualize everything. Nothing can be done blind. It's because it's just too dangerous. But the concept, I think, is interesting. I don't know personally how much it's being utilized, though.
Well, thank you. And I'll just say to Partha, it's not a dumb question. There's no dumb questions.
Not at all.
In the know.
No, not at all.
So,
and something else we didn't talk about, so this will have to be episode 3 for you, Brian.
3-parter.
We didn't even talk about the connection with airway and how we're now taking into account, especially in a lot of these orthognathic surgeries, the appreciable changes that we can see in the oropharyngeal airway, or the impact of anything that we're doing craniofacially
Absolutely.
on the oropharyngeal airway.
Could part 4 be nursing and the impacts of how we're feeding our babies to develop the oral facial complex, and what its impact is going to be long-term?
Brian, I'll tell you what, I'm going to step down. You just take over my spot, because you should be on every
Steps out Brian's end. Wait, Chad, vote.
well, I'm still trying to figure out what the TMJ is, and then Jeff throws in this thing called orpharyngeal. I don't even know what that is. I vote that Jeff steps down and Brian takes his place.
Well, as long as I get whatever's left in that bottle of wine, if there's anything in there.
There you go.
We still got a full half of a bottle here.
Then I'm there.
Brian also works with our pay scale. He's obviously very amenable to our payroll structure.
Oh yeah.
Wine. We can do wine.
That is awesome.
Please subscribe to our Venmo account. I have to bring it up again.
As soon as the donations come in, we're golden.
We're bringing in a new partner.
All right. Well, Brian, thank you again for joining us.
This was great.
What a pleasure to see you again, and we'll be chatting again in the near future. But I would love for you, if you'd be willing to come back on, for us to maybe dive into some pain concepts and maybe even talk about the connection between dental facial orthopedics and the airway.
Absolutely. That would be great. Thank you so much, guys. That was great.
Brian, it's great seeing you.
So much fun. It was amazing. Thank you so much.
And
Brian.
guys, he didn't even finish in the OR till like 6-something tonight. He's texting me. He's like, I'm just leaving the OR. I'm like, don't worry, we're good. It's very casual. So thanks for your time.
No, thank you, guys. I really look forward to doing it again.
Thanks,
and honestly, if you're perplexed, I will tell you that you can always send patients down to the Piper Clinic, where they have made efficient ways to bring people in from out of town, see them, develop a diagnosis over one day. I want to make sure I'm not saying anything incorrectly.
Yeah, they're diagnosed and treatment planned before they're getting on the plane to go home. We have to do it that way. Yeah.
So if you're ever in a bind where you're just like, I just don't know what to do with this patient, that outlet is always there. And I can tell you, they will not receive finer treatment anywhere in the world. So, Brian, thank you again.
Thank you, guys. Have a great night.
He's a great guy. And honestly, all of you looking for any education on temporomandibular joint dysfunction and I just can't speak strongly enough about what they're teaching down there at the Piper Education Center in St. Pete. So
is he teaching as well, or
yes.
Okay.
So yeah, he's involved now with the study groups and in the teaching center, and Dr. Piper is still teaching, which is great.
Just not doing too much cutting.
It's
anymore.
just it's like the dream team. It's amazing down there, and then just the people that go down there, the other dentists, the Jim McKees and the Kurt Ringhoffers, and I could name 20 other names of just incredible dentists that go down there, and we share our failures and our successes, and it's just a great atmosphere, and I just feel like we keep raising the bar a little bit.
Yeah.
So
First off, I would like to thank all of our members for being here. I would like to thank our wonderful guest tonight, Dr. Brian Shah. This week was a huge week for us. We hit 5,000 members. Cheers, everybody.
Cheers, booze.
And it's kind of fitting because it's episode, 102? So
102.
We've been doing this 102 times. It's not getting old. We're having a lot of fun.
I'm still having so much fun.
And we're just getting started.
Me too, but that could be the wine.
Yeah, that could be. We have we have a bunch of wonderful educational partners, but Q Optics dropped a great deal on their loupes, $300 off for a loupe and light combo, and you won't find much better than that.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day.